Welcome to the Endocrine Reproductive Systems TBL9 Female Reproductive Physiology. This is Lynn. Let's go ahead and get started. In this session, we'll cover the following learning objectives. We'll explain the roles of FSH, LH, estradiol inhibin, and oogenesis in follicular maturation, describe ovulation, formation, and decline of the corpus luteum, and roles of hormones in each of these processes. We'll describe the hormonal regulation of estrogen and progesterone biosynthesis and secretion by the ovary, identify the key cells responsible for biosynthesis, the mechanism of transport in the blood, and how they are degraded and removed from the body. We'll list the major target organs and cell types for estrogen and describe its effect on each. Describe the action and cellular mechanism of estrogen. We'll list the physiological actions of progesterone and its major target organs, cell types, and describe its effects on each. We'll describe the action and cellular mechanisms of progesterone and other progestins. We'll illustrate the timing of changes of the blood levels of FSH, LH, estradiol, progesterone, and inhibin, and correlate these structural changes in the endometrium and the ovary seen during the menstrual cycle. We'll describe how the changes in the ovarian steroids produce the proliferative and secretory phases of the uterine endometrium and menstruation and changes in the basal body temperature during the menstrual cycle. We'll also explain the interplay of hypothalamic, pituitary, ovarian, uterine cycles. All right, let's get started. At puberty, a female is born with approximately 1 to 2 million oocytes, and by the time puberty begins, this number has been reduced to about 300,000 oocytes. This is a natural degenerative process called atresia, where it breaks down over time, and the oocytes are then stopped and arrested in prophase 1 of meiosis. Later on, once the sperm comes along, it will finish the mitotic division. During the female's monthly cycles, there's a complex hormonal interaction, stimulation, and maturation of the oocyte, which will then initiate that first mitosis division. And this results into two unequal cells of size. You're going to have this first secondary oocyte that retains majority of the cytoplasm and has resources for maturation and development. And then you also get this polar body. The first polar body over here is what is going to then regress off, eventually disintegrates and divides further into these non-functional polar cell fragments. And then if the fertilization does occur, the final stages of meiosis are then finished and completed. The fertilized ovum will then retain that sister chromatid inside the cell that is needed for genetic material exchange and development. And then a second polar body is then created, which will then follow the next degeneration phase and then further along breaking down. So when you think about the value of the egg and the quality of the egg, it is very important because as we age, females tend to have a poor status, poor quality of egg cells, and the quantity also reduces as well. So that can impact the fertility rates and as well as increase the risk of potential chromosomal abnormalities. Now let's take a look at the overview of the hormonal cycles. So the hypothalamus serves as the brain's control center for reproduction. It secretes a key hormone called gonadotropin-releasing hormone, GnRH, in this pulsatile manner, which is about every 90 minutes. And it pulses with this rhythmic release to control the downstream components. And when there are disruptions to this, it could lead to hypothalamic amenorrhea, where there's change in when the cycles occur and then the menstruation. This can be caused by stress, it could be caused by eating disorders, or even extreme excessive training and exercise, which could alter the GnRH secretion. The anterior pituitary gland is the tier 2, the mediator. This is where it releases two key hormones, the follicle-stimulating hormone, FSH, that stimulates the growth and maturation of the ovarian follicle, and then the luteinizing hormone, LH, which at one point was called the ICSH. This then triggers ovulation, supports formation of corpus luteum, and secretes hormones that are essential for the maintaining of early pregnancies. Dysregulation of any of these hormones can be seen in conditions like polycystic ovarian syndrome, PCOS, which could make fertility a little bit trickier. Over here on the right side, you can see a graph showing you the FSH and LH expressed in nanograms per ml. On top, we have estradiol in picograms per ml. And you can see just in a 28-day cycle, the fluctuations of these hormones. We'll go into a deeper dive of this in a few slides, but you can see, first of all, FSH rises in the first couple of days. It then dips down, and then right before ovulation, it peaks up, the red line. Goes back down again, resets, and then recycles upwards. LH follows a similar trajectory. It's higher in the beginning, it drops down a little bit, raises all the way up to a close to 2 to 3-fold difference, drops all the way back down right before ovulation. And on top, you can see estradiol plays a bigger role in the beginning of the cycle, whereas progesterone takes over in the post-day 14 for the uterine cycle. So let's take a look at the key hormonal patterns. The follicle-stimulating hormone and luteinizing hormone together, they rise during ovulation, with this LH exhibiting this gigantic surge, and we call this the LH surge. This is a push that happens about 24 to 36 hours right before ovulation. This surge is critical for the release of the mature ovum, and then it causes you to develop into the dominant follicle. The FSH hormone plays a more supporting role. It helps with the growth and development and maturation, ensuring that one follicle is only developed so that you don't have more than one follicle. When there are abnormal LH surges or even disrupted FSH levels, this can cause ovulatory disorders such as anovulation or even what we call the primary ovarian insufficiency when the egg isn't fully developed. Then, of course, we have the estrogen progesterone. Estrogen peaks just before ovulation. It promotes the follicular development. It also helps with proliferation of the uterus lining, which is the endometrium, the inner layer. It prepares for the potential fertilization. The progesterone levels begin to rise after ovulation, and this is secreted by the corpus luteum. This helps maintain and stabilize the endometrial lining so that there can be implantation that can occur. Low progesterone oftentimes is associated with luteal phase deficiencies, so there's a luteal phase defect called LPD. This can oftentimes be a result in infertility and even pregnancy loss. One treatment here is that to provide the patient with a longer course of progesterone for the first 10 weeks, and that way it can help nourish the uterus and ensure a better attachment. All right, let's take a look at the follicles. So the ovarian growth and follicular phase. The primordial follicles, these are at birth. Each ovum is surrounded by a single layer of these small cells called the granulosa cells, and then eventually form the primordial follicles. These primordial follicles are going to remain dormant in the ovaries until puberty hits, and then they get arrested in that prophase meiosis 1. At this stage, the oocytes are going to be relatively not active. They wait for activation later on in life. The role of these granulosa cells are really critical. For one, they provide nourishment essential to the supporting of the developing oocyte. And number two, there's also secretion of the oocyte maturation inhibiting factor. This factor helps maintain the oocyte in that arrested state. It prevents progression through meiosis until the right hormone signals are released. After puberty, changes occur and the hormonal changes begin to fluctuate. FSH-LH secretion, as we said before, from the anterior pituitary begins to increase in a cyclic manner, triggering the growth and development of the ovarian follicle. The ovarian and the follicular growth is under the influence of FSH, and then as the ovum enlarges, it prepares for eventually the ovulation event. The granulosa cells will then proliferate and grow, multiply layers around the oocyte, and that signals transition into that primary follicle. On the right, you can see this transitioning phase, so it's going from the primordial follicle to the primary follicle, gets a little bigger. Then we have this developed the maturation of the zona pellucida cells around the egg cell. We develop this fluid-filled compartment with a lot of the hormones and estrogen called the antrum, and this is called the antral follicle. And then once we have a thicker layer of granulosa cells, we have the pre-ovulatory mature follicle, or also known as the Raphian follicle. And then ovulation occurs at day 14, and you have the ovum. And surrounding the ovum is a layer of cells called the corona radiata that protects it. Now let's take a look at the hormonal influence on the follicular development. At the beginning of the monthly sex cycle, the pituitary gland increases secretion of FSH and LH. FSH rises a little bit more prominently. This initiates the growth of about 6 to 12 different follicles during that cycle. And then LH plays a central role in the later stages of follicular maturation and the pushing out of the ovulation. So for the granulosa cells to proliferate, the cells surrounding the oocyte will multiply, forming many layers that provide nourishment and support for that developing follicle. These cells are critical for increasing the amount of estrogen provided and also promoting follicular growth. Theca cell formation is critical. There's two distinct layers. We have a theca cell interna and a theca cell externa. On the right, you can see just the layer of the theca cells. There's the outer layer, and then there's the inner layer. The theca interna is composed of these hormonal secreting epithelial cells that produce mostly estrogen and progesterone. And then the theca cell externa is the vascular connective tissue capsule around the follicle. It helps with the anchorage of blood supply needed for the hormone production. Now, during each of these monthly cycles in the menstrual cycle, there are about 6 to 12 follicles that begin to develop, and under the right influence of FSH, they will then mature. However, only one follicle fully matures and gets to be released, while the other ones are going to go to that breakdown process, which is involution. This is also known as atresia. The mechanism is not 100% well documented. However, this is the hypothesis. We have the mechanism that involves high amounts of estrogen production during this time, and that estrogen is going to cause a follicle that grows larger to become the dominant one because it produces a little bit more of the hormone. There's also going to be some sort of suppression, so as there's elevated estrogen, there is this negative feedback that suppresses the amount of FSH from the hypothalamus, and that reduces FSH secretion, so it kind of isolates that one follicle to be the main one to grow. That then reduces the growth, and that growth suppression will then ensure that the other ones that are smaller don't develop and only one matures. On the right, you can see a picture of this, the primordial follicle, primary follicle, secondary follicle, and then eventually become the antral follicle or the Graafian. And then over here we have the mature form where the egg cell gets pushed out and then ovulation occurs. And the regression phase after that happens becomes the corpus luteum, which maintains progesterone release, and then the corpus albicans, which is a scar tissue at the end. The mature follicle reaches of a diameter of about 1 to 1.5 centimeters at ovulation, which is quite noticeable. Now let's take a look at ovulation. Ovulation timing and its mechanism. So the timing of ovulation is critical. It typically occurs around day 14 in the 28-day cycle. This marks the release of the mature ovum from the dominant follicle, preparing for that potential fertilization. The mechanisms are quite interesting. This goes into several distinct phases. The first one is a follicular wall swelling. The outer wall of the follicle begins to swell due to that buildup of pressure and fluid inside the follicular activity. That then leads to the formation of a structure called the stigma. This is a small nipple-like protrusion called the stigma that forms along the surface of the follicle, and that indicates the ovum's release site. The sequence of events as follows. There's going to be a little bit of fluid beginning to oozing out of the stigma, and as a follicle prepares to rupture, the rupture event takes about 30 minutes, and then that stigma ruptures, this viscous fluid excretes, and then the fluid that contains the ovum is then surrounded by the corona radiata, that layer of protective mass of granular cells, that then gets released out. So on the right, you can see a picture as the secondary goes into the Graafian. Corona radiata around the ovum is then secreted out, and then the corpus luteum is a regression phase in that yellow tissue that digresses into the corpus albicans. Let's take a look at the role of LH in this whole process. The importance of LH is critical. It is the key hormone that acts as a primary trigger for the release of the mature ovum. Even in the presence of a high amount of FSH, the follicle-stimulating hormone, ovulation cannot occur without LH. This is critical. If you don't have both hormones, this will not work. The LH surge, approximately 2 days before ovulation, will see a dramatic increase. This is known as the LH surge. Let's take a look at this hormone graph. So over here on the right, you can see the LH dark line. Right before the ovulation, day 12, 13, it begins to rise. It'll peak almost to about 3 to 4 times the amount by this point. Over here, you can see it's expressed in international units per milliliter in this graph. So LH goes from about 10, under 10 points, close to 10, now eventually rises to close to 40. FSH is a little bit higher in the first couple of days of the month, day 0 to day 4 or 5. Eventually drops down, stabilizes, and also rises right before ovulation as well. So this is what we saw. Well, this is what we call the synergistic role of FSH. During the LH surge, FSH levels also rise, a little bit lesser degree, about 2-fold or so, but both of these hormones together synergize to complete that maturation of the follicle, and that supports the enzymatic processes that will then slowly weaken down the follicular wall that facilitate the boosting out of the ovum. At the bottom, you can see the dotted line representing estradiol. Day 12, day 10 begins to rise up. First peak begins to dip down right before ovulation, all the way down, and then makes a second peak towards the later phase of the 28-day cycle. Progesterone is stabilized and relatively low the whole time, and right after ovulation, 16, 17, 18, it begins to rise to the next peak. The initiation of ovulation and the role of LH, as I mentioned, triggers the key event, and as it rapidly increases, there's also secretion of progesterone-containing steroids from the follicle. That antrum that we talked about will then be burst open. The events that detail within a few hours start out by the capsular weakening. The theca external cells begin to release the proteolytic enzymes that degrade from the lysosome, so it melts off the outer layer cell. These enzymes will then dissolute the follicular capsule, and then that outer wall begins to weaken. Then it swells up, begins to degenerate that stigma that we talked about. Then these new vessels begin to grow rapidly to the follicle's wall. Certain kinds of compounds like the prostaglandins begin to be secreted, and that increases the blood flow and swelling. These are the vascular changes that you can see. Combining all of these together, then the plasma begins to swell up, causing the follicle to then further expand, And eventually, once the sigma is fully degenerated, and the follicle swelling leads to that rupture. On the right, you can see a picture of how this works. The luteinizing hormone triggers the follicular antrum to expand, and the steroid hormones progesterone begin to fill up. Proteolytic enzymes like collagenases begin to weaken the wall, chill down the outer layer. The generation of the sigma begins to occur. On the right side, you can see the follicular hyperemia and prostaglandin secretion, causing that to dilate, and then the transudation of the plasma into the follicle, causing it to swell, and eventually it ruptures out and the ovum's out. So these two processes do go simultaneously. Now let's take a look at the formation of the corpus luteum. After ovulation, the follicular structure transforms into this corpus luteum, a temporary endocrine gland that plays a critical role for maintaining the luteal phase of the menstrual cycle. Luteinization is a fancy way for saying following the ovulation, the granulosa cells and the theca internal cells undergo this process that's triggered by LH. The transformation of these cells into what they call the lutein cells. Lutein cells enlarge. They are doubling in size. They accumulate a lot more lipid, fat-based inclusions inside the cytoplasm. They give this corpus luteus kind of characteristics, which is yellow in color. There's a lot of vascular supply, a lot of blood vessels around this, and it supports that endocrine function. The key hormone production of the corpus luteum. Number one, the granulosa cells still present are going to produce primarily progesterone, and the dominant hormone of this phase or luteal phase is progesterone. It also secretes estrogen, but that helps regulate the endometrium and helps provide some feedback, but the theca cells produce mostly the androgens. Androgens are the male sex hormones. There are two conversions. We have the androstenedione and the testosterone. These are then converted to estrogen via an enzyme called aromatase. The granulosa cells are the only cells with aromatase. The theca cells do not have it. So it's important that you're aware that the theca cells will pump out the precursors, and the granulosa cells then convert the androgens into the estrogen. So the hormonal secretion of the corpus luteum. The corpus luteum that's formed after ovulation serves as this temporary gland that produces large amounts of progesterone and estrogen. The hormonal triggers include the LH stimulation, which peaks at the ovulatory surge. And these hormones are essential for maintaining that endometrial lining for preparing the uterus for potential implantation. There's a programmed life cycle of this corpus luteum. So it lasts of about 12 days. It begins with proliferation. That's the phase where the cells divide and the luteinizing granular cells and the theca cells form into functional corpus luteum. Enlargement occurs. The cells begin to be more vascularized, increasing more support and producing more hormone output. Then we lead into secretion, where high levels of progesterone dominate while the estrogen levels are being secreted, still in a good amount, and it stabilizes the endometrium during that luteal phase. Then eventually, at the end of the phase, we have the degeneration phase. This is if pregnancy does not occur. The corpus luteum will then start to break down into this regression phase of the corpus albicans. And then the hormone production begins to decline. That then leads to the female menstruation. So on the right, you can see a zoom in light microscope 25 zoom of a corpus luteum phase. You can see the cells swelling up, sponging up. This kind of swelling up cells that release hormones eventually becomes the corpus albicans. And this is that scar tissue that is left over. And this is an 80 times zoom that it transitions into. So it takes about that 12-day process. The involution of the corpus luteum in the next cycle. So the role of the hormonal feedback and the cycle regulation. The corpus luteum secretes the following hormones: estrogen, progesterone, and also inhibin during that luteal phase. These hormones play a critical role in suppressing further ovarian activity by creating this negative feedback. Progesterone and estrogen first, they inhibit the secretion of FSH and LH by preventing any development of new follicles during that luteal phase. The inhibin, which is a hormone that specifically targets the inhibition of FSH secretion. This ensures that follicular growth gets suppressed. Around 12 days after the ovulation, day 26 or so of a 28-day cycle, the corpus luteum begins to go involution. This breakdown results in a rapid decline in secretion of progesterone, estrogen, and inhibin. So with the decline of that in progesterone, estrogen, and inhibin levels, that negative feedback on the hypothalamus and the pituitary gland is then lifted off. This allows the secretion of FSH and LH to resume, initiates growth of new follicles, and the start of a new cycle. When there's a low levels of progesterone and estrogen, it also causes the endometrial line to begin to break down, resulting in that menstruation and then the discharge of the menses. Now let's take a look at the role of estrogen and progestins in the female reproductive physiology. The estrogens, particularly the beta estradiol, is the key essential for promoting the growth and function of the female reproductive tissues and development. of the secondary sexual characteristics. So the function is that it helps with the cell's proliferation and growth. It stimulates the growth of the endometrium. It helps with the ovarian follicles and other reproductive tissues. These secondary sexual characteristics include development of breast tissue, widening of the pelvis, and also certain types of fat disposition patterns. There are 3 types of estrogens. The most dominant, most potent is the beta estradiol. This is the one that is used mainly in the ovaries. The second type is called estrone. This is formed in the peripheral tissues with the conversion of androgens, particularly in the postmenopausally. And then the last one is called estriol. This is a weak form of estrogen that has this weaker metabolic byproduct of the estradiol and estrone, and really only serves during the pregnancy. On the right, you can see the pathway going from cholesterol. This is the steroidogenesis, going to pregnenolone, and it goes something alpha hydroxypregnenolone that goes into DHEA, dihydroepiandrosterone. And then pregnenolone can go into progesterone, and it can go over to 17 alpha hydroxyprogesterone and become androstenedione, and that then becomes testosterone. Testosterone will then go to the conversion with aromatase, go into beta estradiol E2, and then E2 can then get converted into metabolite of estriol in the liver, and then the androstenedione can also become estrone E1, which can also be converted into estriol in the liver. Overview of the progestins. Progestins, primarily progesterone, are crucial for preparing the female body for pregnancy and lactation. Here are some of the key functions. The preparation of the uterus for pregnancy. The progesterone supports the endometrial growth and the secretory activity. It creates an environment that's ideal for the embryo. It also helps the preparation of the breast tissues for lactation and milk ejection reflex. This stimulates the development of the mammary gland lobules and the alveoli ducts to help the ejection of milk production. So for the secretion patterns, the non-pregnant females, there is a significant secretion occurs that happens typically in the later half of the ovarian cycle by the corpus luteum. And then during pregnancy, a large amount of this is created by the placenta, especially after the 4th month of gestations. On the right, you can see a visual showing you how the theca cells and granular cells differ. Theca cells have the receptors for LH as well as the low-density lipoprotein, LDL. It then activates the adenocyclase to convert ATP to cyclic AMP. That then converts cholesterol to pregnenolone to progesterone, and progesterone down sequence to the androgens. Androgens get then fed across to the granulosa cells because it doesn't have any aromatase. The granulosa cells have the receptors for the LDL as well as LH and also FSH. The FSH will then trigger the adenocyclase to convert ATP to cyclic AMP. That will then trigger the activation of the aromatase. So when the androgens come across, and androgens get converted to estrogens via the aromatase. Don't forget that the cholesterol can also be converted here into pregnenolone and progesterone, and that can also get fed back to be converted into androgens. Steroid hormones in female reproduction. So the steroid hormones include the estrogens, progestins, which are derived mainly from cholesterol circulating in the blood. They play a critical role in the menstrual cycle, follicular development, and again, the pregnancy phase. Synthesis of the steroid hormone begins with the cholesterol origins. It comes from the bloodstream and is primarily a precursor for steroid synthesis. They can also be partially synthesized from acetyl-CoA directly through the intermediate metabolic pathways. And then the aromatase activity, this enzyme aromatase, stimulated by the FSH in the granulosa cell, is responsible to convert the androgens into the estrogen during that follicular phase. Converting this is essential for the production of the estradiol. This is that dominant estrogen that we talked about. The metabolism and the fate of the ovarian hormones. The estrogen conjugates and form the glucuronides and the sulfates, and about 20% of this is then excreted in the bile juices. Majority of this is then urinated out. There's some of them that gets converted, so the more potent estrogens, estradiol, gets converted into estriol, and then the weakened liver functions can actually then increase estrogen activity because you're not able to convert it to the weaker form. Progesterone gets also quickly rated into inactive steroids. The major metabolite is pregnenolodiol. About 10% is then excreted in the urine as pregnenolodiol. The ability for your body to produce the progesterone can be estimated by the measuring of how much pregnenolodiol is found inside the urine. Now let's take a look at some of the key primary and secondary sexual characteristics and functions of the estrogen. So the primary function is to promote cell proliferation and the growth of reproductive tissues. The target tissues include the uterus and the external organs, enlargement of the ovaries, the fallopian tubes, the uterus, the vagina, the mons pubis, and the labia at puberty. It also then increases the stroma of the endometrium. It also boosts up the glandular proliferation, the coiling that allows implantation support. The vaginal tissue also transitions from a cuboidal epithelium to more stratified texture. And the fallopian tubes also increase the number of cilia to help movement of the egg. The breast tissues are also stimulated. There's more stromal growth, the ductile system gets developed, and also more fat deposition. This helps then contribute to the fuller look of the breast tissue as well as initiating milk letdown reflex. In the skeletal system, it inhibits the osteoclast activity, which then promotes bone growth. So what happens is it can stimulate epiphyseal closure, and when the estrogen gets reduced, then there's a higher chance of reduction of bone density. Estrogen also plays a role in the maintenance of the skin, develops a softer texture, making it more vascular. Let's take a look at the functions of the progesterone on the reproductive organ, namely the uterus. The endometrial changes occurs and promotes the secretory changes in that lining, making it more receptive for the implantation. There's also a reduction in the uterine contraction, so it decreases any contractility, reducing any risk of expelling that ovum or the embryo, especially during that early pregnancies. The fallopian tubes also have an increased secretion. It stimulates that mucosal lining of the fallopian tubes to have more fluid, and it nourishes the ovum and supports the transporting towards the uterus. The breast tissues also develop into more bigger lobules and alveoli. It plays a key role for lactation stimulation and eventually for production of milk in postpartum. The breast tissue swelling also occurs because of the alveolar development and the fluid retention. So now on the right over here, you can see it makes the cervical lining more receptive, mammary gland enlargement, thickening of the cervical mucus. Over here, going through the phases of the uterine cycle, we have the menstruation phase. This is the end of the 28-day cycle to the first couple of days. Proliferative phase is right before the ovulation, and then the post-day 14 is what we call secretory phase. Notice the amount of spiral arteries that develop, and then the size of the endometrium changing over the course of time. Again, showing you that graph of the hormones going through the 28-day cycle. Now let's take a look at the key phases of the endometrial cycle. We have 3 phases. The proliferative estrogen phase. This is also when the growth of the uterine lining occurs. We also have the secretory phase, also known as the progestational phase. This is where there's preparation for implantation. And the last phase is called the menstrual phase, which is the shedding of the uterine lining if there is no fertilization occurring. About 11 days in is the proliferative phase. Post 11 days, 12 days through, including past the ovulation, is secretory phase. And the last 5 days of the month, right around day 23 to day 28, would be menstrual phase. Let's take a closer look at each of these phases to know what exactly is going on and what changes are occurring. In that proliferative estrogen phase, this is right before the ovulation. Some of the key features include endometrium regenerates after menstruation. It gets stimulated more by estrogen, and there's also a noticeable re-epithelialization of the endometrium within the 4 to 7 days post-menstruation. The thickness begins to increase about 3 to 5 millimeters by ovulation. There's a lot of noticeable blood vessels, and the endometrial glandular cells are very, very proliferative. There's also going to be a noticeable cervical mucus plug is also a little bit more thin, more stringy. It helps you allow the guidance of the sperm towards that uterus region. Then we have the secretory progestational phase. This occurs after ovulation, dominated by progesterone and a little bit of estrogen from the corpus luteum. The glandular swelling still is occurring. There's also tortuosity, where it's very curly and spirally. The stromal begins to swell. There's also going to be a lot of depositions of lipid and glycogen that accumulate the nutrient storage. Thickness reaches about 5 to 6 millimeters at peak. Then the final one is going to be the menstrual phase. The menstrual phase marks the beginning of that uterine cycle when the fertilization does not take place. And there's a shedding of the endometrial lining. So number 1, it's declining of the hormones. If there is no fertilization, the corpus luteum then is eventually going to go through involution. That leads into a drop in estrogen and progesterone levels. This hormone then triggers a breakdown of that lining. The second phase is then leading into vasospasm and necrosis. This is a constriction of the blood vessel in the uterine spiral arteries, reduces the amount of flow to the endometrium, and it causes the tissue death of necrosis. Then the last part is the desquamation. Desquamation is when the outer layer of the endometrium begin to separate off from the uterine wall and is shed along with a lot of the blood and necrotic tissue, and this whole process of the drainage is called desquamation. So on average, the loss of blood will be about 40 mLs of blood plus about 35 mLs of serous fluid. During this process, there's also going to be a protective mechanism called leukorrhea. Leukorrhea is when the leukocytes or red blood cells are released along the necrotic material to provide resistance against infection during this vulnerable phase. There is a slight antimicrobial difference because it helps you with a combination of the leukocytes and the acidic fluid of the pH in the vaginal region, helps reduce any kind of risk of bacterial infection. On the right, you can see over here a picture showing you, zooming in into the endometrium, we have the upper functional layer, that's the inner layer, basal layer over here in the middle, shown in purple, and then the myometrium, which is the muscle layer. 3 layers: endometrium, myometrium, perimetrium. We have the internal os, external os, that's the opening, and then we have the cervical canal, and then we have the plug that fills the space over here. The regulation of the female monthly rhythm. The gonadotropin releasing hormone, GnRH. The GnRH is a key hormone secreted by the hypothalamus that plays a central role in regulating the female reproductive cycle. It's secreted in that pulsatile secretion, which pulses lasting about 5 to 25 minutes every 1 to 2 hours, which is about 90 minutes. The pulsatile release is essential for stimulating the anterior pituitary to produce the LH-stimulating hormone and the follicle-stimulating hormone. This pulsatile mechanism is important. It helps with the cyclical regulation of the menstrual cycle, and variations of frequency and amplitude of the GnRH pulses can affect the balance of LH-FSH. So on the right, you can see an experiment showing you the red line representing the pulsatile of the LH in the peripheral circulation, and then the bottom MUA, the minute-by-minute recording of the electrical activity. And so it changes throughout the minutes. You can see it goes up, comes down every about 2 hours, goes up, comes down, peak of about 100 nanograms per ml. The primary hypothalamic centers that regulate the female reproductive functions. The hypothalamus contains key centers that regulate the GnRH. The first one is the arcuate nuclei. This is also referred to as the medial basal hypothalamus, the primary site for pulsatile GnRH release. GnRH pulses originating from the arcuate nuclei and help stimulate FSH, LH for secretion by the anterior pituitary. And this will then affect the ovaries and the overall female sexual activity. Then we also have the preoptic area. This is also known as the anterior hypothalamus. This provides moderate secretion of GnRH. It plays more of a supportive role for maintaining that basal GnRH levels and also fine-tuning if needed. And also the role of the limbic system. So the intensity of GnRH is based on the emotional state, the environmental factors, which could potentially increase or suppress the output of GnRH. And then the frequency of GnRH pulses is based on items like stress, physical activity, external stimuli that could affect the pulses and then regulate the irregularities. So on the right, you can see just how intricate it is. LH comes out from the armpit, FSH comes out from the armpit. These will then target the ovaries. We went over the theca cells and the granulosa cells. They will then take the androgens to convert that into estrogens. Estrogens will then affect tissue. Progestins are also created by the theca cells that will target tissues. There's a negative feedback that comes back, and then with the help of inhibin, which is released by the granulosa cells, they will then turn off the release of FSH. This will then have behavioral effects onto the brain. As you can see, there could be some reinforcing effects to the hypothalamus and also reinforcing of the hypothalamus stalk. So namely inside the arcuate nuclei and the preoptic area. The negative feedback regulation of the estrogen, progesterone, inhibin. Estrogen and progesterone feedback. Estrogen levels are pretty low and it exerts its negative feedback on the hypothalamal pituitary axis. It inhibits the secretion of the LH and FSH from the anterior pituitary during the early follicular phases. Progesterone combined with estrogen together will provide a much stronger inhibition of the GnRH release, particularly during that luteal phase. It prevents any kind of premature follicular development. Feedback mechanisms is as follows. So the ant pit is going to act on the primary site for inhibition. This will then reduce the amount of release of the gonadotropins, the FSH and LH. The hypothalamus alters that RH pulse frequency, which will then modulate downstream the secretion of LH-FSH. So what's the function of inhibin? There are 2 types of inhibin which we'll talk about. There's inhibin A, inhibin B. The source is secreted by the granulosa cells, and then by the dominant follicle, and then eventually later by the corpus luteum. The primary target is that it inhibits the secretion of FSH, predominantly acting to suppress any kind of follicular recruitment. There might be some moderate effects in inhibition to LH, but mostly it's the FSH inhibition. The main difference of the inhibin A and B is that inhibin A tends to be produced mainly by the corpus luteum, but also a little bit by the placenta, where inhibin B is secreted mostly by the antral follicles in response to FSH. Both of them do help regulate the amount of FSH. So positive feedback effects of estrogen and the pre-ovulatory LH surge. Typically, the estrogen exerts a negative feedback, right? This helps suppress the gonadotropin release. However, when estrogen levels rise significantly in the late follicular phase, there tends to be more of a positive feedback mechanism. This high levels of estrogen will stimulate the anterior pituitary to then boost the release of the LH, and that will then cause the LH surge. To a little bit of a degree, also a little bit of FSH. This surge is critical for the ovulation and then eventually formation of the corpus luteum. So it should be noted that LH increases by 6 to 8 times, FSH by 2 to 4 times. The role of progesterone in the LH surge is that just before the LH surge begins, granulosa cells do begin to secrete small amounts of progesterone, and this progesterone may amplify the LH surge further by stimulating the anterior pituitary. This will then ensure that the follicle then ruptures at the optimal time for ovulation. So clinical application here is that this positive feedback loop of estrogen is pretty important for that ovulation event. Any kind of disruption can result in anovulation, which is a failure ability to ovulate. And again, going back to infertility issues like PCOS, this could be an issue. Let's take a look at the onset of puberty and menarche. Menarche is defined as the first menstrual cycle marking the transition into the reproductive maturity. The timing typically occurs between ages of 11 to 16 with an average onset of about average of 13. Menarche is influenced by genetics, environmental factors, nutrient factors, and there's a lead up of a gradual increase of gonadotropin hormones. The levels of LH and FSH begin to rise progressively to stimulate the ovarian activity. It increases mostly around age 8 as it accelerates towards puberty. During childhood, the GnRH, gonadotropin, maintains pretty minimal and is pretty stabilized, preventing any kind of gonadotropin, FSH, or LH release. Right when the onset of puberty occurs, it begins pulsatile. That triggers that release of LH and FSH from the anterior pituitary. And it is believed, again, this is a theory, that the limbic system inside the brain, namely for memory control and also amygdaloid body for emotional regulation, is believed to have a role in initiating this GnRH release. The mechanism may be linked to the emotional state as well as environmental factors, timing of around the puberty. It shows that abrupt increase in gonadotropin release being excreted, whereas for males it tends to be a little bit more of a flat line. Over here on the bottom, showing the age, between age 13 to 40, the amount of estrogen excreted in urine is much higher, meaning there's a lot more higher activity of estrogen. And then right after 40, it begins to dip down, and that's when there's a drop of the estrogen levels. Menopause is the permanent cessation of the menstrual cycle. Definition: timing. Menopause marks the permanent cessation, typically occurring between ages of 40 to 50. This signifies the end of a female woman's reproductive years due to exhaustion of the ovarian function. Physiological changes include the depletion of the primordial follicles, where there is really no more primordial follicles left. Without these follicles, the ovaries are no longer able to produce sufficient amounts of the hormone. This decline of estrogen and progesterone is because there is not much any more active theca cells and granulosa cells, and therefore drops close to almost zero. This hormone decline then leads to cessation of ovulation and menstrual cycles, and that's why you see a lot more FSH and LH in the urine after 40 years old. Because of that rise, there's nothing to bind, therefore most of this is lost out. Over here on the right, you can see perimenopause. Estrogen level begins to decrease as the ovaries begin to run out of eggs. The ovulation becomes irregular. The thickness of the uterine varies according to the hormone level, and periods also become more irregular. Then once you hit postmenopause, there's very little estrogen release, the ovulation does not occur, and the uterine lining does not thicken, and periods generally don't occur. Here are some abnormalities that could occur in the ovarian secretion. Hypogonadism. This is when there's a reduced ovarian secretion. Oftentimes it could be genetically predisposed, where there's poorly formed or even absent. Females will lack the secondary sexual characteristics. Prolonged bone growth due to this delayed epiphyseal closure. We then may see amenorrhea and irregular menstruation cycles. Some of the causes include just having a hypogonadic situation. Hypothyroidism is oftentimes linked to this as well. And also failure for ovulation due to this insufficient amount of LH being released. In some rare cases, we can even have hypersecretion. This is oftentimes caused by tumor cells inside the granulosa layer. Excessive estrogen gets promoted, uterine endometrial hypertrophy, and there may be irregular spotting or bleeding, oftentimes one of the first signs of a tumor in this area. Hormonal suppression for the fertility pill. One application here is that using estrogen and progestins can actually prevent that pre-ovulatory LH surge by blocking ovulation. So a patient may take the synthetic hormones to replace the natural ones because there's a better chance to block ovulation. So there are these synthetic estrogens like the ethinyl estradiol and menstruinol, and synthetic progestins like norethindrone or norgestrel. This is taken during the early cycle phases to stop and allow menstruation, and it's quite effective. The failure rates of it not working is about 8 to 9%. You can see over here, this is a graph showing you body temperature, degrees Fahrenheit, over the course of the cycle. One way that we could also track ovulation is by looking at the jump in body temperature. So basal body temperature increasing by about a fraction of a degree Fahrenheit is a good indicator of showing you that when ovulation occurs. So you can see the temperature begin to jump right at the ovulation